Hello, everyone. We will give it a minute as we see that participants are joining the webinar, and we will get started. Okay. Welcome, everyone. My name is Lourdes Prechada, and I'm here today to host the new virtual highlights from GRAPPA together with Fabian Proft. If you've joined these sessions before, this is an interactive session in which we present the most hot abstracts and posters from the latest conferences in dermatology and rheumatology. So welcome, Fabian, to today's session.
Thank you, Lourdes. Yes, it's always a pleasure being here with you and having the young Grappians under supervision of senior GRAPPA members presenting the highlights from the recent conference. And especially for me now, bringing in the rheumatological perspective and needed to miss EADV that just recently took place in Paris. I'm really excited to hear from you guys what was the most important things around psoriatic disease, and I hope it's the same for you. And as you might be familiar, we have structured this around 3 thematic schemes. We have basic science, we have clinical topics, and we have the highlights about treatment. And yeah, really looking forward to hear the expert presentations by the brilliant young Grappians. And what is really important, we also want to get your perspective and your questions. So if you have any questions, please put them in the chat function so we can bring them to the speakers and the senior GRAPPA members and discuss within our group. And without any further ado, I think, Lourdes, we are ready to get started.
Great. Annie, could we pass to the next slide, please? These are our disclosures, and we have one more slide. Just a brief overview, as Fabian mentioned, this is how we're gonna organize the agenda for today. So we're gonna start with basic science, we're gonna continue with treatment highlights, and we're gonna end with clinical topics and a panel discussion in which we will invite our patient research partner, Martin DeWitt, to also contribute the patient perspective to these discussions. So with that, I'll hand it over to Ahmed. So if you want to start sharing your screen, our first presenter is going to be Ahmed Ugur Ötilan. He's an assistant professor of dermatology in Turkey, and he's going to be presenting to us on basic science. And he has been supervised and supported for this presentation by Dr. Johan Good-Johnson. So whenever you're ready, feel free to get started.
Thank you so much, Lourdes, for a nice introduction. Yes, it's my pleasure to present these important psoriatic disease posters from EADV 2025. And it was my privilege to be supervised by Johan Good-Johnson. So let's start. These are our disclosures. And today we selected 3 great abstracts, I think. So, but just to shorten the names, in first poster, we will look at can stress really trigger psoriasis? So we will look for an answer. And then we will look for some gene signatures can predict treatment response or not. And in the last study, we will look at psoriasis is one disease, but really one disease or it has some different phases. So let's start with our first poster. So it's named targeting neurogenic skin inflammation in stress exacerbated psoriatic mouse model. So probably as we all know, many patients say our disease are activated by psychological stress, but unfortunately we don't have any clear data about it. So in this study, they wanted to answer this question, and they also wanted to show can we mitigate this pathway, this neurogenic or psychological pathway. So in the study, they used a different kind of psoriasis model. So in this slide, I wanted to summarize it. They employed immune-compromised mice and healthy human skin. They xenografted these healthy human skins. Also, they collected peripheral mononuclear blood cells from these humans, and they activated them with IL-2, and then they injected these mononuclear cells, and they said psoriatic lesions developed and they were reinnervated and they had almost all psoriatic changes. So they showed these parts in the previous papers. So, but in this one, they exposed these mice sonic stress or not. Also, they used topical steroid therapy. They used some neuroimmune pathway inhibitors, for example, NGF antibodies, ketotifen, corticotropin resolving hormone receptor antagonists. So to inhibit these pathways. So let's look at the results. In the first slide, they said stress enhanced psoriatic lesions. And even though we employ topical steroids, the therapeutic response was low. Also, they showed stress elevated psoriatic cytokines. Also, as we can expect, stress also triggered neurogenic inflammation like NGF, neurokinin 1 receptor, substance P, etc. So, and then they pass to second phase. So can we inhibit these pathways? So they used anti-NGF and anti-corticotropin releasing hormone receptor antagonists and ketotifen. So when they employed these treatments, they showed that epidermal psoriatic features decreased, immune cell infiltration and psoriasis cytokines decreased, neurogenic inflammation decreased, mast cell activation decreased, angiogenesis decreased. Also, tissue remodeling markers like matrix metalloproteinase also decreased. So, what they found to sum up, yes, stress, at least the sound stress can trigger psoriasis. And if we inhibit neurogenic pathways, we can also suppress these psoriasis activation. But they had some limitations. This mouse model, sonic stress model, we can discuss if we can generalize it for humans. Also, they just studied acute stress. They didn't mention about chronic stress. So there are some drawbacks, but again, they have great insights about neurogenic inflammation in psoriatic disease, I think. So this was our first study, and now our second study. Also, I think it's a great study because they wanted to show if there are some ways we can predict which patient can respond better to other treatment or other treatment. So for this aim, they recruited 34 patients, and before treatment, they collected skin samples and plasma samples, and then they started adalimumab for anti-TNF arm and risankizumab for IL-23 arm. And with these pre-treatment samples, they studied transcriptomic and gene ontology studies. So first, when we looked at patients' characteristics, IL-23 arm patients were older, they had higher PGA scores, and they have more biologic use history. Otherwise, the groups were similar. So first they looked at lesional versus non-lesional skin. When they looked at, they found more than 100 genes expressed differently. And when they studied protein-protein interaction, gene ontology studies, especially Th17 pathway, chemotaxis pathway, lymphocyte migration pathway, and antimicrobial hormone response pathway were activated. And then when they studied their interactions, especially four proteins, chemokines or cytokines, were found that highly interacted with other pathways. So IL-6, CXCL8 and 10 chemokines, and CL20 among the more important proteins. And also they showed correlation with disease severity, both PACE scores and BSA scores. Also, they did the same thing with plasma proteins. They again found CCL20, CXCL13, IL-6 were elevated, and especially CCL20 were correlated with disease severity and disease activation. So, and then they looked at their main aim, if we can predict treatment response. So They followed these patients until 6 months, and then if they have PACE 0 score, so they accept them as responders, good responders. For anti-TNF alpha and for IL-2 and 3, they defined different genes, but again, among these 5 predefined genes, but there were different. So they said that we can use these genes expression, pre-treatment expression for treatment response. So to sum up, they found some transchromatic genes were focused on some specific roles, and especially CCL20, CXCL8, and IL-6 can be used as treatment response predictors for IL-23 inhibitors and anti-TNF alpha, but they didn't do any functional validation of these gene interactions. But again, I think this is important because for precision medicine, these results can be used as biomarkers. So, and my third abstract, and in this study, they looked for if there is any difference among different body sites psoriatic lesions. As we all know, scalp psoriatic lesions, lower extremities psoriasis lesions are more resistant to treatment. So, but we don't know if there is any difference among these different body sites. So they recruited 12 patients and they collected from them non-lesional trunk biopsies and lesional scalp, lesional upper extremity, and lesional lower extremity biopsies. And they looked on them immunohistochemistry and spatial transcriptomic profiling for each level if there is any difference. For histology and immunohistochemistry, there was no difference among these body sites. For scalp, lower extremity, upper extremity, they were all the same. But when they looked at for spatial transcriptomic findings, there were lots of different expressed genes, and especially they showed that IL-23 levels was higher in lower extremity epidermis. But when they looked at IL-17 signals, it was elevated all lesions, scalp, upper extremity, or lower extremity. But IL-2 and 3 was different. It was just higher in lower extremity lesions. So to sum up what they found, we can use again these results for location-specific approaches. So, for example, if they have maybe higher lower extremity lesions, maybe we can use IL-23, or we can use at least these results for precision medicine. But again, they didn't look at deeper compartments or plasma levels or systemic inflammation, but again, it was great. So to sum up all studies, in the first one, we see that stress can aggravate psoriatic lesions, and we can mitigate this pathway by inhibiting neurogenic pathways. And we can use some biomarkers to predict treatment response, especially for anti-TNF alpha and IL-2 and 3 inhibitors. And in the third one, we saw that for some different body sites, they can have different transcriptomic findings, especially for IL-2 and 3 in lower extremity, although they have similar histology and immunohistochemistry. So thank you for your attention, and I can take any questions if you have.
Thank you, Ahmed, for this brilliant presentation and for bringing the key highlights from EADV on basic science to us and to me as well. So again, a lot, very interesting topics. And I think it would be great if the audience, if you have any questions, please drop your questions in the question and answer. And in the meanwhile, we have the pleasure also welcoming Johan Gudjonsson, a real expert in dermatology from the University of Michigan. Johan, great to have you here as well. And maybe I can start with a question from the rheumatological perspective. And because we all know that this is something the patients experience, and this is about stress-inducing autoimmune flares. We see this a lot in rheumatological practice where patients just tell us that there's a clear correlation between work and personal stress and their disease flares. And do you think that we can also extrapolate the results that you have shown here from the mice also on psoriatic arthritis? Any ideas on that? Ahmed, what would you say?
For me, for psoriatic arthritis, I think it is more complex disease than skin psoriasis, to be honest. So, but I think Professor Gudjonsen will have a better answer for us.
Well, I think there's no clear or right answer on this, but I can just contribute with my perspective that this really is something that the patients experience and that they tell. And we can also ask Martin about his personal experiences with this. But this is something that I frequently hear in my outpatient clinic, that they say, well, I had a disease flare, but this was clearly connected to work stress and or personal stress situations, and now the stress resolved and also the flare is getting better, something like this. Martin, how is this? How has this been for your personal experience, and what do you hear from other patients experiencing psoriatic arthritis?
Yeah, I hear the same thing. Many patients talk about stress flare in their disease, and it's one of the most commonly reported factor that seems to kind of influence disease when you ask patients themselves. But at the same time, it's something that is very difficult to define, what do they mean by stress? How do we define it on a molecular basis? And how do you reproduce that in your model systems? And obviously, mouse models are helpful, but again, they sometimes simplify things quite a bit. So I think in many ways we haven't really resolved this yet.
Thank you. And also on the second abstract, I saw the rather small numbers. And do you think that the biomarkers that were presented are really coming to clinical implications in the nearer future? Ahmed, what is your take on that?
Yeah, especially for the second one and third one, I think it's can be helpful, especially when we talk about these TRMs. So, and really we are struggling to treat scalp or inverse psoriasis. So I think, yes, it will be important. But to find clear biomarkers is quite hard because most patients are not naive patients. Usually they had some previous treatments. But yes, I think it will be possible in the near future.
Yeah. I can certainly add to that. I think if you really want to do patient stratification, you need a big cohort and then you need a validation cohort. And it's very difficult to do this with, when you only have 20 or 30 patients in your cohort. You need hundreds to really do this well. It's recommendable that people are trying to do this, and I think in many ways that abstract kind of picks up some of the key nodes, key immune pathways that are involved in psoriasis. But I do think that we need bigger studies and more robust studies with validation cohorts to really get to it. But I agree with Ahmed. I think this is possible. But it takes a lot of work, and we need a lot more.
Lourdes, what is your perspective on the presented abstracts?
First, thank you both so much for these wonderful presentations. And my question is about the third abstract, in which they were trying to differentiate these markers across different locations and sites, right? So what was your impression when seeing those results? I could resonate, like the fact that they saw something different in the lower extremities resonated with what we would see in clinic, right? Sometimes patients do tend to have a more recalcitrant disease there, but I cannot necessarily associate it with, okay, how did it go when patients were treated with IL-23s, right? So what were your perspective when looking at this? Does that resonate with what you see in clinic when treating patients with IL-23?
I think yes, because usually knee lesions. Also, in my experience, many patients says my disease started from my knee, so my lower extremity. So probably in the future, also they will look at maybe TRM levels in different body sites, so it can give some clue about where this disease starts maybe. So is there any start points? Maybe we will see it. And why is it different? So for functionality of these results also important. So IL-23 is important, but why is it important there? And what does it mean? So is the result or is the cause of disease or something? So yeah, it's hypothesis generating abstract, but there are lots of hypotheses in our minds. But to validate them, we need really big studies.
Thanks. And I'm inviting all the dermatologists in the room to talk, so it doesn't have to be just Ahmad. If anybody else wants to come and has any insights, you're welcome to contribute to this session, to this part of the Q&A too.
And I do have a question coming in from the audience, and I think this would be great to also capture this one. So the spectator thought that IL-17F should be more involved with the occurrence of flares in PSO patients, but the study showed also IL-17A as increased in the stressed mice, and just wanted to hear the perspectives from the experts here in the group. Any thoughts on that?
I am not sure if they studied IL-17F. I think they just stained IL-17A, so we don't have probably IL-17F results. So it is another limitation of this abstract, I think.
I agree. Yeah.
Martin, you had your hand raised. I don't know if you wanted to add something.
Yeah, I was just wondering if I understood and heard well. It was about that some biomarkers express on the lower extremities, and the suggestion was that we have to look for local treatments. But I was just, if we think about clinical implications, to what extent is it possible to administer our current effective treatments locally? I mean, I'm just thinking about, is that a reality? Is that something that we should strive for in the near future?
I may try to
It
answer.
could be, for example, for our patients, if they have some calcitrant resistant plaques, we sometimes use intralesional steroids for small plaques if they are so resistant. But we don't know why they are resistant. All body, maybe PASI 99 is okay, but why this PASI 1 does not get better, we don't know. Maybe for these, again, yes, they will get systemic treatments, but for these really resistant plaques, maybe we can discuss in the future these local treatments, and we will maybe again local and targeted therapies in the future. Maybe creams or interlesional applications.
Yeah, one thing that I want to kind of point out is that if you look at the data from that abstract, it's not that the response is qualitatively different, it's just quantitatively different. So it's like the response is a little bit higher in the, lower extremity. And I think that kind of fits with what we see clinically, that those places often kind of tend to kind of respond more slowly. And there has been the knockout study that Andy Blauwell did, and by using higher doses of anti-IL-23, you could get a shift in the response by about 20 or 30%. So you got to the point where almost everybody cleared. So I think in many ways, at least for some of the biologics, we might be just underdosing them to really shut things more effectively down. And probably for some of them, it probably is safe to do so. So I think that's one way, but I agree also that we could go at it by kind of treating those residual plaques with another agent. One thing that I've used myself in the clinic is to treat those residual spots with agents such as tapinarof, AHR agonists. And I've had good success with that. I think you can also do the same thing with topical PDE4, and certainly also by more aggressively treating them with steroids, although I think that's less effective.
Thank you. May I add an extra comment? I think also it is the reason, for example, we blocked their IL-2 and 3 pathways, but still probably there are some background patterns we don't suppress. So for these patients, maybe tapinarof or more, maybe, I don't know, other topical JAKs maybe can be effective, because maybe for these lesions, maybe we need more than just one pathway. Maybe we need to block more than one pathway. So for this residual plaques, yeah, tapinarof really good choice. Thank you so much.
Yeah, thank you all. Thank you for the brilliant presentations and the insights we gathered. And I think we are ready to move on and go to the next major topic and coming to treatments. And I'm really happy to announce my friend and colleague, Maria Angelica Gini. Margot, it's a pleasure to have you here again. You were supervised by Professor Álvaro González Cantero, and we're really looking forward to the newest highlights on treatment of psoriatic disease that were presented at EADV. And yeah, the stage is yours, and really excited to listen to your presentation.
So thank you very much for the introduction, Fabian. It's a real pleasure to be here with you today, and it has been a real pleasure working with Alvaro on this topic, which is a really hot topic for us, because at the end of the day, what we are doing, we are treating our patients, and we are trying to do the best for them. Here are disclosures, and the first abstract that I selected was the abstract from Visible Study. So Visible Study has two cohorts, so that's why you can see here cohort A. And actually, what it was about the use of guselkumab that actually worked quite well in terms of skin clearance and health-related quality of life scores up to week 48 in patients with moderate to severe plaque psoriasis across all skin tones. So why I selected this abstract? Because we all know very well that patients with skin of color, we tend to use different terms. Some people say diverse skin tone. Some other people, recently here in UK, we are talking about richly pigmented skin, but we are all talking about the same population. So we know very well that this population has been underrepresented. So when we are looking at our atlases, when we are looking at our books, when we are looking even now at online atlases, still the number of patients with darker skin is much smaller compared to the white population. And also, despite the efforts that we have seen during the last 10 years, I would say, in research in order to be more inclusive and include more patients with skin of color, still these patients are underrepresented in clinical trials. And we worked with the International Psoriasis Council, actually, and many IPC experts in the field of psoriasis and for the population of diverse skin tones. And actually, what we saw is that there are definitely some differences in genetics. Clinical presentation sometimes may vary. For example, we see more of post-inflammatory hyperpigmentation, but in terms of treatment outcomes, we have mainly data from post-hoc analysis. So we don't have dedicated studies for patients with darker skin tones. So that's why I selected Visible, because Visible is the first study of its kind that includes patients that self-identify as patients with skin of color, with moderate to severe plaque psoriasis. And it was a study actually that assessed guselkumab versus placebo, and we wanted to see how these patients are doing. So here you can see the study design. We're focusing on the cohort A. So the cohort A means moderate to severe plaque psoriasis with a PASI of 12 or more. I think that's what we mostly use in our clinics. I mean, IGA is more relevant for the Americans. And these patients were randomized either to the guselkumab group or to the placebo group. And the placebo group at week 16, they were all started on guselkumab following the initiation dose. So the first injection at week 16, the second injection at week 20, and after that, injections every 8 weeks. And here the investigators looked at the IGA, the PASI, the BSA, the skin clearance outcomes, and the health-related quality of life scores through week 48. So what we are seeing here, we are seeing the results about almost clear skin, clear or almost clear skin. So we're talking about PASI 90 and an IGA of 0 or 1. So the patients who were on the guselkumab group, they achieved a higher percentage of patients achieved that. And also what we are seeing is that we're not looking only at week 16, we're looking up to week 48. So these percentage of patients who achieved that was maintained until week 48. And actually for clear skin, so clear skin is pretty impressive, but we are so happy now because we have treatments in our armamentarium and we can achieve that for our patients. We can see that patients from week 16, a significant percentage, I would say, achieved completely clear skin, not even a tiny patch of psoriasis. And actually this percentage increased over time, as you can see at week 48. And here we can see also the mean percentage improvement from baseline in terms of BSA and in terms of PASI. And we are seeing again really high percentages in terms of percentage improvement. And no matter what we say, no matter what we see as healthcare professionals, what matters a lot is also what patients feel and what patients experience. So that's why personally I'm really enthusiastic when I see more of patient-reported outcomes, more of how patients are experiencing the disease. And here we are seeing that we have the PSSD score. So this is an 11-item score. It assesses many different parameters like itch, pain. And here we are seeing a significant improvement in terms of itch. So in conclusion, at week 48, for the patients who were treated with guselkumab, they were randomized to the guselkumab group, more than 70% achieved clear or almost clear skin, and more than 50% achieved complete skin clearance. So we're talking about, I think we're talking about some really good results. We didn't see any safety signals. So the safety profile is the classic, I would say, consistent safety profile that we have seen with guselkumab in other populations, like the white population. I would say also that the scores are similar to the white population, and that is pretty amazing. So what we are seeing is that actually guselkumab can be effective. It can have a durable effect for patients with moderate to severe plaque psoriasis up to week 48. And we are really looking forward, because this is an ongoing phase 3b trial, so we are looking forward to the long-term results, but also to the other cohorts that include scalp psoriasis and other parameters. So that was my first abstract. And the second abstract has to do a bit with psoriatic arthritis. So Fabian, this is a bit more relevant for you, actually. So we are looking at bimekizumab and whether bimekizumab actually can have an effect on psoriatic arthritis symptoms and the development of psoriatic arthritis in patients who have just psoriasis and some specific risk factors for disease progression. So I think it's a really hot topic. This is something that we are all discussing. Who are the patients who are going to develop psoriatic arthritis? Many of them, they have risk factors and they may not do that. There are many different, tools, and there have been prediction models that have been developed trying to assess this risk. And also the really hot topic is whether biologics can actually prevent or delay the development of comorbidities like psoriatic arthritis. There have been many systematic reviews, many papers. I just selected this one, and I think we need more data at the end of the day. And why I selected this abstract, because there were also other biologics assessing something similar. I decided to do that because bimekizumab, it's the newest kid on the block in terms of biologics that have been approved both for psoriasis and psoriatic arthritis. Yes, we have some new biosimilars, but this was the last biological agent that got approved for psoriatic disease. So we really want to see how it works. And also we have had a really good experience in terms of skin. So we want to know what is going also with the joints. Because yes, our rheumatologists have started using it a lot. Also, we are seeing the results, but what happens in terms of prevention? So here, that was a bit of the introduction actually and the objectives. So the key objectives were to evaluate whether patients will develop PSA symptoms. So these were patients who were included in the B-radiant study, and they had only psoriasis at baseline. Nevertheless, they had some risk factors like scalp involvement or nail involvement. And the questionnaire that was used in order to assess that was the PACE questionnaire. And also they wanted to assess the 4-year incidence of PSA treatment emergent adverse events in the bimekizumab treated population. And we just wanted to see how these patients were doing. So all these patients, they were stratified in groups based on the baseline PSA risk factors. So we're all aware of the PSA risk factors like, severe disease, high BMI, nail involvement, scalp involvement, also, cardiovascular comorbidities. We have also Alvaro here that is dealing a lot with risk factor for cardiovascular disease and cardiovascular comorbidities in psoriasis. And the PACE questionnaire, it's a tool. It's a 15-item tool used to assess the potential development of musculoskeletal symptoms in patients with psoriasis that may develop PSA actually. So 15-item questionnaire, each question gets a score from 1 to 5. And here, what we are seeing, the PACE 47 actually is the cutoff. So if a patient has a PACE more than 47, this is probably a reason to see a rheumatologist and be assessed for psoriatic arthritis. So what we are seeing here, and what I love, is these almost horizontal lines. And why do I love horizontal lines? Because that shows stability over a period of years. And we are seeing that irrespective of the number of the risk factors that these patients had, more or less, very, very few developed symptoms of psoriatic arthritis. So in conclusion, what we saw was that the vast majority of patients in the B-radiant study, they did not report symptoms of PSA. Also, the year of PSA treatment emergent adverse events was low throughout the period of 4 years across all the studies that the data were pooled. And this was irrelevant to the number of the PSA risk factors. So if you had 1, if you had 4, more or less it was similar. So the conclusion was that potentially bimekizumab used long-term could be used to manage psoriasis and reduce the risk for progression to PSA. But also what is very, very important in this abstract, and always a kind reminder for us as dermatologists, is that we need to screen our patients for psoriatic arthritis. We need to intervene early, and we need to do that because normally we are the first physicians that the patients will see. And my third highlight, I think I'm okay regarding time. So this is the oral treatment. This is going to be a game changer molecule, I would say, in the management of psoriatic arthritis from a practical point of view. So we're talking about icotrokinra. So we are seeing here the results from the phase 3 studies, the ICONIC Advance N1 and 2. And actually, icotrokinra was compared to placebo and to another oral molecule, which is deucravacitinib, which is one of the latest oral treatments that have been approved for the management of psoriasis. So we're seeing a head-to-head study between 2 oral molecules. So that's why I got really excited about that. So here, what we are seeing is that we have many options in our armamentarium. And when we are looking at the small molecules, when we are looking at the oral treatments, until now our options were a bit limited. So we had apremilast, we have now deucravacitinib, and there are more things coming like icotrokinra. And why is this important? Because we are also busy in our clinics. Our patients, they are not very excited to come to the hospital. They are not very happy with injections sometimes when they inject themselves at home. And what it was shown here is if patients, find a treatment that works for them and they can take that orally, they find it quite good because also it reduces their anxiety in terms of the injection process. Icotrokinra is the first in class targeted oral peptide. What it does, it selectively binds the IL-23 receptors, and actually it inhibits the IL-23 pathway signaling. So we have had until now, really encouraging results from the first phase 3 studies, but this is the first study actually comparing it to another oral molecule like deucravacitinib. So here you can see the study design. In terms of the inclusion criteria, it's the classic ones that we have, patients with moderate to severe plaque psoriasis, a PASI of 12 or more. In other trials, it may be PASI of 10 or more, actually. And they need to be candidates for systemic treatment. And also in this study, the patients should not have a contraindication for deucravacitinib. So patients were randomized to the icotrokinra group, to the placebo group, and to the deucravacitinib group. And the placebo group and the deucravacitinib group, at some time point, if the patients did not reach specific targets, they were switched to icotrokinra. And here we are seeing the results. So we are seeing the rates of IGA of 0 or 1 and PASI 90 at week 16. And here we are seeing what is happening. So icotrokinra, it's the purple, and deucravacitinib is the black, and the gray is the placebo. So we are seeing, even quite early actually, a significant percentage of patients who were on icotrokinra, and they did really well in terms of PASI 90 versus the deucravacitinib group and versus the placebo. We see that both in the advanced 1 and 2. And we are seeing also the score PASI 90 here. So approximately, I would say 65% of patients on icotrokinra at week 24 had achieved a PASI of 90, which is really, really good when we're talking about an oral molecule, because until now, the oral molecules were a bit more limited in terms of efficacy. And here we are seeing the complete skin clearance. We're talking about IGA 0 and PASI 100. And again, here, almost I would say, 38% of patients at week 24 achieved completely clear skin, and almost, 44% of these patients an IGA of 0. So everybody will say, okay, amazing results, oral treatment has really good results, but what happens in terms of safety? So the safety profile seems to be really seems to be acceptable. What we are seeing is that patients experience on icotrokinra experience less infections compared to the deucravacitinib group. So that's important because this is one of the commonest side effects that we will see with these molecules. And in terms of the gastrointestinal side effects, again, the deucravacitinib group, they were a bit higher compared to the icotrokinra. A good safety, an acceptable safety profile for this oral molecule. So in conclusion, what we saw was that icotrokinra demonstrated significantly higher rates versus deucravacitinib in terms of almost clear skin and completely clear skin. A safety profile that is acceptable, no new red flags compared to what we knew. We are very excited about the future and about the management of our patients, because we're going to have an oral treatment. So it's going to be a tablet once daily that is going to have encouraging results in terms of the management of the disease. So I would like to thank you very, very much. And
thank you so much, Margot. That was fantastic. You really made us all very, very interested in everything you were saying with your enthusiasm. And so now I want to invite Álvaro González Cantero. He's a dermatologist in Madrid. He specializes in psoriasis. He has his own clinical trial center and has an extensive curriculum in association between cardiovascular comorbidities and psoriasis, as Margot pointed out before. So both of you, do you want to make any special comments on the abstracts presented? And in the meantime, people are invited to submit questions for the Q&A session. And the panelists, you're all welcome to raise your hand if you want to make a question too.
Thank you, Lourdes. Yeah, I want first to congratulate Maria Angeliki because she has done a great job in taking all the data. She did everything, and does such a fantastic presentation. So I think Fabian want to comment.
Okay, I'll just post one question, Fabian, before from the Q&A, and then I'll go to you, okay? So there's a question that says, did you test if when used at early stages of PSA onset, bimekizumab is able to slow down the progress, worsening of the skin symptoms compared to people that are not on biologic treatment?
So this was a head-to-head, so the BRADIANT study, it was a head-to-head study with secukinumab. So the patients were on a biologic agent, but then the post-hoc analysis included also other studies. So some of the patients, they were initially on the placebo group and then they were switched to another agent. Mainly there were people who were treated with a biologic agent. It would be very interesting, to see a large cohort of patients being followed up, over a long period of years and seeing what is happening. So recently, there was a study that was published in rheumatology by the rheumatology group from Dennis McGonigal, actually. And they assessed the potential effect of anti-TNFs versus patients who were on phototherapy for their disease. Not something that we do really routinely, but these patients were followed up over a period of 10 years. And actually it showed that the patients who were anti-TNFs, did better compared to treatments who were using topicals and phototherapy. So I think we have a lot of work to do, towards that direction. But I think, the main point is that we are really understanding the need to assess early the psoriatic arthritis activity. And number two is, since we are intervening, we need to follow up these patients over a long period of time and see the results. So perhaps national registries can also, be very, very, useful for this type of studies because we need really long periods.
Thank you. Fabian, and then I'll go to Anna.
Yes, and I just wanted to also phrase the question that was coming into the chat, but also contributing with my perspective. And I think this is a very hot topic. And I think here psoriatic disease in general is really the role model for being able, accepting the disease before we have the outbreak of psoriatic arthritis, because we see the skin psoriasis earlier. And so I think also a little bit philosophically, maybe if we hit hard and early and treat intensively the skin component, maybe we don't need the rheumatologist later on because we just cure the psoriatic arthritis. And on the other hand, I think comparing to phototherapy, because I think we have agreement within our group, if we treat skin psoriasis with any biologic, we will have also a positive effect on any musculoskeletal symptoms. But the key question is there one mode of action superior to the other? And there were also some registry data or data from larger cohorts indicating superiority for modes of action. And I think here we would really need to have long-term head-to-head data with high numbers to really be able to say, well, in this patient, because of these risk factors, we administer this specific compound because the risk of developing psoriatic arthritis will be lower in the long-term run. So I think this will be the main question, and really excited for what the future holds. And I think this will really be something like the holy grail in psoriatic disease.
Sure. Yeah, I think that's one of the most we understand that this is gaining attention in a meeting where we are together, dermatologists and rheumatologists, because I think we still need to build evidence on convincing dermatologists to treat, for example, these risk factors for PSA or the mechanism of action, and that we have observational data, but we need clinical trials or even head-to-head clinical trials prospectively with similar inclusion criteria to really know what the mechanism of action that we should use as dermatologists, because we see the patient before sending, and we have that opportunity. So, but we still need more evidence, and I think it's being a lot of noise and a lot of comments on different mechanism of action. But I think we need to be critical on some of the data that we have now. So this is just building on the knowledge, or this is a post hoc analysis. So we need to design specific trials to really know what we need to do. Anna, I think.
Anna wants to comment, yeah.
Thank you, Alvaro. So I completely agree with you all, with Margot, also with Fabian, and also with you, Alvaro, because I think it's one of the key topics that we have now in psoriasis and psoriatic arthritis. But I don't know if you agree with me, but I have the feeling that maybe it will be more dependent on how early we treat the patients, more than which is the drug that we are using to treat the patients with psoriasis. So maybe we need to do prospective studies with patients with long-term of disease, instead of big data with registries and so on. Because I think that now we have data with big registries and big data, also with TNF-alpha, also with IL-17. We have seen data that you show, Margot, with bimekizumab, and we also have data with IL-23. So with prospective data and taking into account the early patient, but early patient with psoriasis. Study this patient in the long term and to see which ones are the ones who are having psoriatic arthritis, and in fact, when do we need to treat these patients? Do we need to treat mild psoriasis to prevent psoriatic arthritis, or only treat severe patients of psoriasis? So it's a little bit my feeling at that moment with the evidence we have in the literature.
Fabian, I see your hand raised.
No,
I love this
I
Q&A.
think
It's
it's
very,
really-
it's very
And really something that we can look forward to the future when we are getting
Yeah.
more and more results coming out for this. And I think having here even though it's a post hoc analysis, but also having a prospective part of it, it's really significantly contributing to our better understanding. And I think therefore I'm really always enjoy having these meeting highlights presented to us. And maybe if we
Before
can...
I jump into Margot's comment. Oh, if you're done, Fabian.
No, yeah, go ahead.
No, I was just going to say, and emphasizing the study design, having a dedicated rheumatologist to assess this diagnosis, because a lot of the data that we analyze in psoriasis tends to be based on screening questionnaires, because that's what we have, right? And no blaming anyone. We even do that type of research too, because of the limited availability of rheumatologists in our typical environment to do it. So the power of combined clinics and collaborating with rheumatologists to really conduct these studies in the most optimal way, I think has a lot of place here. And Margot, you have another comment?
Actually, Lourdes, great minds think alike. So that was
Okay.
my point. So when we are looking about all these things, we're using all these different questionnaires. As dermatologists, we tend to use the PEST questionnaire that I know that rheumatologists hate it. Here we see another question. So I think we all, to align, we need also to include imaging, because this is another important factor when assessing psoriatic arthritis, also specific, markers and all these things in order to diagnose early and monitor and, come to a conclusion. And as Alvaro said, yes, we need more clinical trials. So looking forward to the future.
And maybe I think we have the 2 more minutes that we can talk about this session, because we talked all about one abstract, but there were 2 other
Yeah.
great abstracts that we discussed, right? The skin of color abstract and the one on the oral IL-23, which is really groundbreaking, right? And so I'll pose a question for Fabian here, like, how is this being received in the rheumatology community? Is there any already preliminary data about oral IL-23s for John, like thinking about like how guselkumab is now shifting a little bit how we thought about IL-23s for psoriatic arthritis? So what are your thoughts on that?
Well, this is something that we in the rheumatological community monitor very closely. And I think also it's important to mention that this was presented 24 weeks data now at EADV, but just very recently, I think 2 weeks ago, was the publication of the 16 weeks data in Lancet. And I think this is something that we really also just saw with great enthusiasm. And the studies in PSA are also underway, so they just started. And so I think this oral IL-23 will also hopefully become an option for patients with psoriatic arthritis and also come to the rheumatological community. I would be curious also just from your perspective, because if you would be devil's advocate, you could say, well, you used here deucravacitinib as a comparator, which is not the most effective treatment that you have for treating skin psoriasis. So how would you assume from the data you've seen and your experiences from the clinical trials when the oral IL-23 inhibitor would be compared to the real biologics and the best in class of treating skin psoriasis? Will it be the same, or what is your assumption on this, Margot?
So that's a good point, but I think the comparison was very, very important, because at the moment when we are comparing oral treatments, it's really important to have some data, doing this comparison between 2 oral treatments. So for me, that was very, very crucial. Otherwise, I think, and Alvaro can comment on that, I think icotrokinra has also data and comparison with biologics, right?
Yeah, so it's already started a clinical trial with icotrokinra versus ustekinumab. So they are comparing both drugs now. We are starting the trials, and you will have your answers soon with the clinical trial. But for the efficacy that we see, you can see that when you compare to other orals, it's superior and could be similar efficacy as compared to some biologics. So yeah, it's interesting. The mechanism of action for B is really interesting. It's the first peptide, which is different from a TYK2 inhibition and different other things that they can have this selectivity with the receptor. So it is so interesting. And for me, it's also really, really interesting to see the results of the PSA clinical trial. And just to comment on the visible study, for me at the beginning, when I saw the design, was difficult to understand the significance of it, but mainly due to my ignorance. But then when I thought, which is the rationale for this study? Like, is the genetics of the patients? Is about, for example, when you measure PASI, you cannot measure the erythema well, but then when I travel to different countries to give talks, and people there, they are really looking forward to see the results. They want to see their if they are represented there, they want. So it has the relevance that I didn't understood because of my ignorance at the beginning, but now I see that it has lots of interest, both that we need to have diversity and representation in clinical trials to understand that, and so it's interesting to me but as you know, when you travel, you become more humble, and you understand that there are other interests. So for me, it's really interesting.
Wonderful.
And
I'm sorry, Marco, but we have to move on to the last session. So thank you for all those wonderful presentations and discussions, making this so interesting. Thank you both so much, and all the panelists that participated. But we're going to move on with to the last session so that we are fair to all the speakers. So we're going to move on to clinical topics, and Yusuf Kan-Erek is going to be presenting. So welcome, and he has been, if you want to start sharing your screen, Yusuf.
Yeah, I'm sharing it.
Oh, we cannot see it right now.
You
Let's
can
see.
see right now.
There we go. Yes,
Okay,
perfect.
perfect.
So go ahead. The floor is yours.
Okay. Thank you. Hello, everyone. First of all, I want to say thank you to GRAPPA and Young GRAPPA team for gathering all of us in this important meeting. And today we will talk about clinical topics studies, which presented in the 2025 EADV Congress. Here you can see our disclosures. When we look to our presentation plan, we evaluated studies in the two groups. That one is comorbidities and the second one is imaging methods, which are very important on psoriasis and psoriatic arthritis. And total, we will present 3 studies under these 2 titles. In the first sections, we will talk about psoriasis and comorbidities. Our first study was from Spain and evaluating relationships between lifestyle and cardiometabolic comorbidities of psoriatic patients. Psoriasis is a chronic inflammatory disease associated with increased risk of metabolic comorbidities such as metabolic syndrome, obesity, type 2 diabetes mellitus, and steatotic liver disease. The persistent systemic inflammation observed in psoriasis contributes this metabolic disturbance. Lifestyle modifications, particularly diet and physical activity, have been proposed as potential therapies to improve psoriasis and these metabolic comorbidities. The aim of the study is to evaluate the relationships between clinical course of psoriasis and patients' lifestyle and its associations with metabolic complications. This study was a cross-sectional study and included 278 patients with moderate to severe psoriasis. Patients' clinical data, psoriasis severity, comorbidities, and metabolic parameters were not. And in the lifestyle habits, 2 questionnaires was used. One is PREDMET, evaluating Mediterranean diet adherence. The second one is Godin, leisure for physical activity. If we talk about the results, 22% of the patients had metabolic syndrome and 36% got hypertension, 58% got steatotic liver disease. If we talk about the physical activity and healthy lifestyle, which means diet and physical activity, 13% of the patients were physically active and 7% followed a healthy lifestyle. In the results sections, they found that a healthy lifestyle was independently associated with lower prevalence of steatotic liver disease and better sleep quality. In addition, physical activity was linked to a reduced risk of hypertension in psoriasis patients. In the discussion, the study highlights that significant role of lifestyle factors in managing cardiometabolic comorbidities and improving life quality in psoriasis patients. In conclusion, we can say lifestyle modifications, particularly physical activity and adherence to Mediterranean diet, may reduce metabolic comorbidities in psoriasis patients. These findings support integrating lifestyle interventions into psoriasis management as a therapeutic strategy. In the second part, we will look to imaging in psoriatic disease. Our first study was from China and about ultrasonographic evolution of the psoriatic arthritis in the early stage. Bone erosion is a predictor of the progressive joint injury, and early identification and effective treatment can reverse poor joint destruction and poor prognosis. The aim of the study is to identify association between clinical and ultrasonographic features with bone erosions developed in the early psoriatic arthritis patients. The study included 82 early psoriatic arthritis patients with articular and or the endothelial involvement, less than 6-month durations. That was prospective observation within 24 months of follow-up. And patients' clinical characteristics, demographic evolutions, treatment modalities were analyzed. they performed ultrasound, peripheral joint ultrasound, and on 12th and 24th months, they calculated MASEI, Matrix Sonographic Enthesitis Index, and DACTOS score, which named Novel and Reliable Dactylitis Global Sonographic Score. An erosion was identified as cortical defects greater than 2 mm in diameter with an irregular floor on ultrasonography. If we talk about the results, 82 patients with early psoriatic arthritis were included, 91% got psoriasis, and 35% got nail psoriasis. And they found that early psoriatic arthritis patients who developed bone erosions got later onset of the disease, higher proportion with metabolic syndrome, and greater number of swollen joints at baseline examination. And during the 24 months of follow-up, patients without bone erosion developed a higher proportion of using interleukin-17 inhibitors. Also, they found that DACTOS score and higher age at symptoms onset can be predictors of the erosions. In conclusion, this study demonstrates that ultrasonographic dactylitis and older age at onset are identified as significant risk factors for bone erosions in early psoriatic arthritis patients. And ultrasonography can be very helpful and beneficial in the early observation of the patients. After joints, if we talk about the nails, very important and challenging involvement of the psoriasis, we will present a study from Turkey, clinical, dermoscopic, and capillaroscopic evolution of the psoriatic nails and its associations with psoriatic arthritis. Psoriasis is a chronic immune-mediated inflammatory skin disease, and nail involvement in the patients can vary from 10 to 90%, and this frequency is higher in patients with psoriatic arthritis. The aim of the study is assess prevalence and morphological characteristics of nail findings in psoriasis patients with and without psoriatic arthritis using clinical examination, dermoscopy, digital dermoscopy, and capillaroscopy. They got 70 psoriasis patients and 60 psoriasis patients with psoriatic arthritis. They evaluated 1,300 nails. They looked clinical examination, dermoscopy, digital dermoscopy, and capillaroscopy. In the results sections, following the 1,300 nails evaluation, they found that pitting was most common findings with 87.4%. Also, onycholysis, splinter hemorrhage, and subungual hyperkeratosis was the other findings. Following the statistical analysis, they found that in psoriasis patients, nail crumbling, onycholysis, splinter hemorrhages, and oil drop signs were significantly associated with increased psoriatic arthritis risk. And also, they calculated three scores: capillaroscopic NAPS score, dermoscopic NAPS score, and clinical NAPS score. They found that capillaroscopic NAPS score yield the higher scores than the dermoscopic NAPS score and the clinical NAPS scores. All NAPS scores were significantly higher in patients with psoriasis and psoriatic arthritis. Apart from the pitting, all nail findings were observed more frequently with the imaging techniques than the clinical examination alone. And also they found that capillaroscopy was the most effective method to detect splinter hemorrhages, oil drop signs, and microvascular damage-related findings. In conclusion, we can say that a combination of clinical examination and imaging methods can be helpful on detection of subclinical findings, assessment of nail psoriasis severity, and earlier identification of high risk for psoriatic arthritis. Following three studies, in conclusion, I can say that cardiovascular disease is a significant comorbidity in patients with psoriasis. Patients should be questioned about these comorbidities, and these comorbidities should be considered when planning treatment. Lifestyle is an important step in the management of these comorbidities and psoriasis. Ultrasonography has an important role in the early detection of psoriatic arthritis, and use of dermoscopy and capillaroscopy in the evolution of nail psoriasis will be very helpful in diagnosis and follow-up. So thank you very much for your attention.
Thank you so much, Yusuf. This was brilliant, and you were perfectly on time. So this gives us the opportunity to have some in-depth discussion on the clinical abstracts, but also invite the whole faculty for the panel discussion. And I would like to start, because I don't see any questions from the audience at the moment, and directing to you, Martin, to get your perspective from the patient perspective, both on the treatment section, but also on the clinical section. And I can just endorse this because this is really one of the most frequently asked questions in my clinical practice, that the patients with both skin psoriasis but also psoriatic arthritis are asking me about advice for their nutritional behaviors and get some expert opinions and suggestions how to improve their overall well-being with physical activity and diets. And so I think, Martin, any particular thoughts on the two topics presented, and how are you dealing with discussing nutritional behaviors with your clinical colleagues?
Yeah, I know and I agree. There are many patients who are thinking about, do I have to change my eating and food habits? And actually, we all know that if you follow common sense, that we know what healthy food is. I think it's good what we hear about the Mediterranean diet. I think that's something that that you as health professionals can always advise and suggest to patients. But overall, it's the same, I think, also for the advice around physical activity. And even if we go back to the very first abstract, which was on stress, we also know that and people and patients, if they experience, and now I indeed can talk also from my own experience, that I know if there is work stress, it has an impact on my psoriasis symptoms. So I think it's also an advice to people to not only follow common sense, but also, and that's part of it, listen to your own body. So I think we know that also stress has a negative impact. Physical activity will absolutely be helpful in even in pain relief and things like that. So I think that indeed health professionals and you should pay attention to this kind of lifestyle components. We all know they are important, so it's important. Just one remark about all the other things that have been said. Just a common comment. It has been said that there should be more clinical trials. I would be in favor of trying to get more multi-omic studies, so more also in the basic and translational field, and really trying together to get more and bigger studies using large data sets. And for instance, I know from the Hippocrates Consortium, they have built a huge platform with multi-cohorts included that can be used for discovery, but also for validation studies. So I would also try to suggest that if you are looking for that kind of conducting that kind of studies, to have a look at the Hippocrates website, because I think there is a huge database that offers a lot of opportunities for collaboration. And then I think the biggest question for patients is really, I feel that all treatments currently do have the same effect, the big problem is that we don't know which patient will respond to which treatment. And that's for me the biggest challenge, not to develop new treatments. We have effective treatments, but we just lack good tests to advise who should have which treatments. So these are just some as a patient, the things that I'm really interested in to see more. I hope this is helpful.
Thank you so much, Martin. Yes, this is really helpful to get your patient perspective, but also your expert perspective on this. Really appreciate it. I see that Alvaro has also something to contribute. Alvaro, the word is yours. You're still muted.
Sorry, yeah, it's a small comment and a little bit of self-promotion, because we've done published last week the first clinical trial randomized control with the Mediterranean diet in psoriasis. So I wanted to share just the paper and the results. I think you can see my screen.
Yes.
Okay, so we published in JAMA Derm, and what we found is 3.4 points in reduction of PASI score in this clinical trial. So I don't know if there is something like that, a clinical trial in PSA, but this is now generating hypothesis for a second one. And as it's really, really recent trial, and it was a lot of effort from our group, I wanted to share with you because we are very excited with this, and not all about biologics, and also lifestyle is relevant. So just wanted to share this with you.
Thank you for that, and congratulations. Maybe you could share the link to the full text also in the chat, because I would love to read it. And it's also in rheumatological community. It's a hot topic, but so far there's no randomized control trial on this. So I think
there's the DIPSA study from Lihieder and Alexis Ogdi, that they did a randomized trial, I believe, using with the Mediterranean diet. So maybe you can look into that one, the DIPSA study. But I'll hand it over to Margot, that has her hand raised.
But I think it's not fully published yet, Lourdes. Or did I miss it? I saw abstract results, but I have not seen it.
No, exactly. Not published, but there is a study ongoing. That's what I mean.
Yes. Yeah, sorry.
Yes, so there are a few other studies, like the Apple study from UK, the Mango study. So more and more people are focusing, on epigenetic factors, like diet, obesity and activity. Just my comment about all these aspects. I really believe that we should treat our patients holistically. But from a practical point of view, yes, the data are encouraging about Mediterranean diet. Yes, we know that. But from a practical point of view, we need to take into account other factors, and especially social factors. So for instance, if somebody, wants to do a Mediterranean diet, they need to eat fresh fish, let's say, twice per week. They need to use, olive oil. So people from a specific socioeconomic status, they are not really able to deal with these challenges. And it's the same again with activity for patients who are a bit more obese. So, it's really encouraging now to have more robust study data about these parameters, because actually over a longer period of time, this should be on prescription for patients, specific food or, exercise, and provide to everyone these options, because otherwise, many of these patients, they will be just excluded because it's not feasible to do these interventions in their everyday life.
Anna, please go ahead.
Yes, I only to add that I think that changing lifestyle in patients is always a challenge. It's similar to when we ask patients to lose some weight. It's always difficult. I think it's almost impossible. And even in Spain, all of us follow Mediterranean diet, but even Spanish people are losing this habit. So I think it's not easy. It's something that results are very good in clinical trials. We can get good results because we know it works. We know that patients that modify lifestyle factors and reduce the weight, get better, and have better outcomes when they are treated with biologics. But it's a real challenge in clinical practice because I think it's difficult for them, for the patients, to do that and to change the way they live. But I think what we need is to change, to convince the patients in the society, to convince them that if they change their lifestyle, if they reduce weight, they will feel better, the psoriasis will get better, and everything will work better. So I think this is the key from the clinical trials and the results and the clinical practice. So I think it's a big gap in between.
Yes, I agree completely with you. It is a challenge, but we should just keep fighting for it. And I know I agree with
Of
Margot's
course.
perspective, like raising the awareness that food is treatment, right? Like, and lifestyle becomes treatment too. I think that there is a lot of value in that too. And then comes all the part of advocacy for it, and to how can we actually make a change from that perspective? I think it's on us to show the evidence so that then we can fight for these new policies that are going to protect those that have less resources, right, to take care of themselves through these mechanisms too.
And this also brings us to another topic, because I don't always want to search for the easy solution and not change the lifestyle habits and just take another drug. But I think, as we are perfectly aware, that also obesity is the main driver of inflammation in both psoriatic arthritis and psoriatic skin disease. And now having also really good randomized controlled trials on combination therapies of GLP-1 agonists with other biologics. And I think if the patient is really able to lose weight and reduce the inflammatory burden by obesity, I think this can significantly also impact the quality of life of psoriatic disease overall. So I think we are really here at an exciting time, and really looking forward what the future holds.
I see there are questions in the chat. Oh no, that's our chat. And do you want
to? There was one question. I'm still not 100% sure if I just posted it into the chat. After controlling the disease, does the disease could develop to psoriatic arthritis? For example, the disease flaring up of skin lesions is associated with psoriatic arthritis. And maybe if I understand correctly, I could rephrase it. I think there's a clear correlation between skin and MSK manifestations. However, we also frequently see that there's a disconnect, right? That the skin is well controlled and the joints are flaring up and the other way around. So I think this is not always so logically that if we control the skin disease, also the MSK component is controlled. And therefore, I think it still makes sense that we are fighting together, both from the rheumatological and the dermatological part, and joining up forces.
maybe thinking about the other abstracts? So there was another abstract from the clinical topics on nails. You have a comment, Anna, on that?
Yeah, I have a question for you, for rheumatology, your opinion about dermatologists doing ultrasound in joints, entheses, and so on, because now, at least in Spain, there is a lot of dermatologists who are using ultrasound for the skin, of course, mostly for HS and other skin diseases, but some of us are trying to learn or to be more skilled in the use of ultrasound in joints and entheses, but it's not we are not very skilled in that, so we are not experts in the joints and in the musculoskeletal apparatus. So do you think that we can address certain entheses or joints that are more commonly affected in early psoriatic arthritis to help you to treat patients earlier? I think it's difficult, but even to start clinical trials together and so on. What is your opinion?
No, Yes, I absolutely love it. And because we have now a growing armamentarium for us, right?
Yeah.
Because there are cheaper ultrasound devices, the handheld ultrasound machines that are then also more feasible to bring into clinical practice on the dermatological level. And we also have AI coming up. So this would also maybe empower us in the nearer future to have support in imaging assessments. And I think this will be the future because especially when it comes to enthesitis, I think the clinical examination is just lacking specificity. And here I think there's also a very nice project in Germany, and I think there will be some similar projects around the globe where we were teaching our dermatological colleagues not to get the most advanced expert, but having the basic skills and focusing on the relevant joints that are also easy to assess. And I think this really makes sense. And we just heard earlier from Lourdes that depending on the geographical location, there's always a shortage of rheumatologists to get to send your patients to. So I think it is the way to go.
Thank you.
And then we are 2 minutes away, but just posing the question, how feasible do you see rheumatology that dermoscopy is going to be used to detect psoriasis findings in nails? Do you
sorry, Margot. I think that dermoscopy is using in our everyday clinics. So it's not the future, it's the present. Maybe the capillaroscopy that is commonly used by rheumatologists in other diseases can be introduced also in the diagnosis of PSA. And sorry, Margot.
Yeah, I agree. That's what I would say, actually. You know,
I misplaced the word. Go ahead. Okay, well, I think that we can wrap up here since we're at the time. We want to thank you all for your tremendous participation today, for putting so much effort into these presentations and making time to participate and share your knowledge with all of us. Thank you, Annie, for your tremendous work behind the scenes to get all of this together. And Fabian, do you want to announce the next session that's coming up?
Absolutely, yes. And I also want to just follow what you just did, because the 3 presentations were just outstanding and I really enjoyed all of them. And also a big shout out to the young Grappians that were developing and presenting, but also the senior Grappa experts that were supporting and supervising when constructing these presentations. And it's always a pleasure, and yeah, really looking forward to it. And one especially topic that we have to highlight, because this was live, but the recording will also be available. So please share it within your network, because you can use this also for future educational events. And we are already ahead of the next virtual Congress highlights, because in 2 to 3 weeks from now, the rheumatological community will meet in Chicago for the American College of Rheumatology conference. And we will discuss all the highlights from the ACR 2025 and the next GRAPPA Virtual Congress highlights that is going to take place on November 12th. So mark the calendars, and we are really looking forward to seeing you there when we will be discussing the newest highlights on psoriatic arthritis here.
Wonderful.
So thank all of you for your attention. Lourdes, thank you so much for your brilliant leadership on this. And as you said, also Annie and GRAPPA administration for all the logistical support. And yeah, stay tuned. And it was a pleasure.
And Martin for sharing all the patient perspective as always. Thank you so much. Have a nice day, everyone. Bye.
Bye-bye. Thank you.
Bye. Thank you.